Hey, hey,
Is that
I
better?
see Dr. Davis.
Hello, Dr. King-Mullins. Okay, good. Perfect.
Hey.
Awesome.
So first, I just want to start off and just welcome all of our viewers, listeners, whoever is gonna, download this later. So welcome to the Love Below. I'm Dr. Erin King-Mullins, also known as Dr. Tushy Touchup. And listen, I am so excited to introduce you all to my work wife, Dr. Mitzi Davis.
Hello, everyone. Thank you so much for welcoming me in your space. I'm super excited to talk about women's health today. That's what I talk about every single day.
Every single day, every single day.
Every
So,
single day.
ladies, every single day. We are wrapping up Women's Health Month, and it's also Mental Health Awareness Month. We'll touch on that just a little bit too, because it definitely plays a role in the conversation that we're having. So, we're continuing this The Love Below series because there is not a lot of open talk and discussion about what happens down below. And when I say down below as a colorectal surgeon, obviously I'm talking about the colon and the rectum, but there's so many other things that happen down there. You know, you have the urinary system. For women, we have the gynecological system. And today we are talking with Dr. Mitzie-Ann Davis, who is a board certified GYN oncologist. Okay. So not only oncology, right? So treating cancer, but GYN oncology, right? So we're talking about specific women focused cancers.
Yes.
So I want you to just take a minute, just tell us a little bit about you, how you got into this field, and your why.
Sure. Again, thank you so much, Dr. King Mullins. Really appreciate you sharing your platform with me so that we can educate women. So, I'm a gynecologic oncologist, which is a mouthful. It just means that I'm primarily a surgeon, but I also give chemotherapy and only for GYN cancers. So, that includes uterine cancer or endometrial cancer, cervical cancer, fallopian tube cancer, and ovarian cancer, vulvar cancers, that's on the outside, as well as vaginal cancers and primary peritoneal cancers. And of all the subspecialties, I work very closely with Dr. King Mullins and colorectal surgeons because we're all in the same area. So you have the bladder, the GYN organs, and the rectum. And unfortunately, sometimes cancers that start in my area can spread to these surrounding areas and vice versa. Sometimes there's a colon cancer that presents in the GYN organs or some other leukemia, some other type of blood cancers. So we work very closely together. I get very passionate and very excited about talking about women's health and especially GYN oncology because this typically happens in older women, but we have seen a lot of young women with this. So anybody of any age can be diagnosed with these cancers, that can be treated with these cancers. And education, knowing these early symptoms of these cancers, can literally save your life and can improve your overall survival.
Yeah. And so I'm actually going to take a super quick shift a little bit because you and I are seeing, the world is seeing such a revolution in the focus on women's health, right?
Yeah.
So perimenopause care, menopause care, just basically like women advocating for themselves because unfortunately a lot of the serious conditions that affect women go either masked or they can mimic other symptoms or other diseases and they get discovered relatively late. Sometimes women are told that their symptoms are due to, oh, it's your time of the month, or oh,
Yeah.
it's because you had kids, or oh, it's just because you're older. And so there's a lot of mental anguish that some women face when they're trying to present their symptoms to their physician, because you've lived in that body your whole life, right? So all of a sudden something happens. Yeah, perimenopause and menopause is traditionally a more gradual, so you know that you're going to have a little bit of changes in your appetite, your sleep patterns, some of the things. But some women experience like really abrupt changes in what their baseline is, and they're told that it's, oh, dude, because you had kids, you're just getting old and this and that. And so that can cause a lot of mental anguish. So let's talk a little bit about like the risk factors for some of the gynecologic factors and when should a woman really be, high tuned to if they feel like they're being brushed off? what they should really bring to the forefront to some of their doctors that they're seeing.
Okay, so you've touched on several different things. Okay, I'm
Sorry.
going to start. No, 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 that's good. I am going to start with, can these GYN cancers, the symptoms of these GYN cancers, can they be masked? Can they present as other things? And I'm going to start with ovarian cancer because we call that the silent killer. Why is that the silent killer? Because the symptoms are vague. They're non-specific, okay? And so we typically as women chalk this up to, oh, we're getting older. Oh, I had a burger. Oh, I had sushi that wasn't quite right. And the main symptoms of ovarian cancer include bloating, changes in your bowel or bladder habits. So you might get new onset constipation that, again, you chalk up to, oh, maybe I wasn't eating enough roughage or I had something different. Fatigue, oh, I'm getting older, oh, I'm really tired. So these symptoms are non-specific. And unfortunately, 70% of the time when we find ovarian cancer, it's already a stage 3 or stage 4. And there are no good screening tools for ovarian cancer. I'm going to
Yeah.
repeat that, woman. There is no good screening test for ovarian cancer. And so, and the reason is, a good screening tool is one that picks up something in its precancerous phase so that we can stop it right before it leads to a cancer. Unfortunately, when ovarian cancer presents, it's already a full-blown cancer. And
Yeah.
even though it is treatable, typically when diseases are in a stage 3 or stage 4, it's advanced and it's not curable. Curable meaning that we're going to give you chemotherapy or radiation or whatever it is, and that the likelihood of it coming back is low. That's just virtually unlikely, okay?
Right.
So we touched on symptoms that can be non-specific. The other cancer that I treat that is the most common GYN cancer is endometrial cancer. Now, risk factors for endometrial cancer includes being a woman, being over 55, number one, being overweight. When we have extra fat cells, that converts to estrogen and causes that lining to get thicker. This presents itself as either postmenopausal bleeding. You haven't had a period in 5 years, 20 years, 30 years, all of a sudden you have bleeding. Women, please do not normalize it. I can't tell you how many times I hear that story. I went to my doctor, oh, they said I was menopausal. Well, if you're menopausal, you should not be bleeding. Menopause means that your
It
period has
stopped.
stopped. At least 12 months, it has stopped, okay? If it starts again, you need to get it checked out. Conversely, young women, especially young women who are very overweight, again, they can also have endometrial cancer. And that presents itself as abnormal bleeding. You're having heavy bleeding. You have to wear a diaper. You're going through 5 pads, 2 tampons every 3 hours. This is completely abnormal, okay?
Yes.
You need to go and get checked out. And that cancer can be diagnosed very simply in the office with something called an endometrial biopsy. If the endometrial biopsy is inconclusive or they weren't able to do it, then we take it to the operating room and we do something called a DNC under anesthesia where we can open the cervix and get a good scraping, okay? This cancer, even though it's the most common cancer that I see, has very good prognosis. Most women, because they realize that I haven't had a period in 5 years, this is wrong, something is wrong, and get it checked out right away, we find it when it's a stage 1. The survival rate for stage 1 endometrial cancer, over 94%. Over 94%
Yep.
of patients are still going to be alive 5 years down the road. The patients that die from this are patients that, one, have aggressive type, and I'll talk about that in Black women in a minute, but 2, the ones who wait for a long time.
Yeah.
So you have to listen to your body, as Dr. King-Mullins had, alluded to. If something doesn't feel right, get it checked out. And also, you're always open to a second opinion, guys. Don't feel like you're married to that one doctor. If you feel the energy isn't there, or the person isn't listening to you, or your needs are not being met, go find somebody else. There
Yeah.
are a lot of doctors all over, but
Right.
you have to listen to your body, okay?
Yeah.
And then I'm going to talk about Black women and endometrial cancer. So even though endometrial cancer is more common in white women, it's more deadly in Black women because we tend to get the type 2. The type 2 is the more aggressive histology. These histologies include papillary serous, carcinosarcoma, clear cell, and these, by the time we find it, they have already spread outside of the uterus.
Yep.
Those patients, regardless of the stage, stage 1 or stage 4, they're going to need chemotherapy. And the relapse rate, aka the rate of it coming back, is higher than like a low grade
Yep.
endometrial cancer. And Black women, for reasons that we're still trying to figure out, sometimes it might be the hair products, sometimes it might be genetics, so all sorts of different things. But we are at increased risk of having those aggressive types of cancers.
Yep. So let me just pause real quick and just say, like, that whole last 5 minutes was like literally a sermon for some people
Oh,
that
I
are
know.
on this. Like, because, so first and foremost, and I feel like you and I connect and vibe on this really well because, and one of the reasons that you and I have a good relationship with each other,
Mm-hmm.
and with our patients is that we make it plain.
Yes.
There's certain things that there's just no waffling about, right? And so also down to the core of the patient physician relationship. Okay. This is a relationship. So we have to agree on certain basics, certain values. So just like, if you may be of one socioeconomic background, status, religion, ethnicity, whatever, you may not be able to marry someone from outside of that. Same thing with your physician.
Yeah.
We may not be able to marry each other because we have certain goals, certain things that are hard stops, are red lines. But at the same time, like if you just not understanding what I do, it's funny. I'm gonna take it back to the remember that movie Rush Hour. Can you
Yeah.
understand the
I know,
words that are
right?
coming out
I
of my
didn't even
mouth?
understand that if you're
Like
in the OR.
if you literally can't understand what I'm saying,
Yeah.
like there's no way we're going to be able to overcome certain obstacles for me to
Yeah.
be treated appropriately. So
Yeah.
I'm the first one to tell you that if you're coming to see me for a colorectal complaint, if you're not understanding what I'm saying, if you don't agree with what I'm saying, like please go somewhere else. And that's not being rude. Go somewhere where you feel comfortable, where you're going to get the care that you need.
Absolutely.
So it is not wrong for if you seek care and you feel like your needs aren't being met or addressed, or you just want to know what maybe else out there, because we all have different training backgrounds, right? If
Mm-hmm.
you train in a major academic institution, a community-based practice, East Coast, West Coast, if you train in a primarily cancer-focused center, or primarily whatever else focused center, your access to certain resources, even as a physician, might be limited. And so your doctor may only literally be offering you what they feel comfortable with providing or just the resources that they have. So let's just make sure that, those are being addressed. Um, and so again, and all of that stuff again, besides that being Women's Health Month plays into the mental health month because you may be like super stressed out over there trying to figure out like how to move next based upon what's going on physically with your body and how that's impacting you mentally and being able to care for your family, your kids, do your work and all of those types of things. So thanks for kind of making some of that stuff plain and differentiating that.
Mm-hmm.
Um, so for those who have just joined us, Dr. Erin King-Mullins, Dr. Tissue Touchup, colorectal surgeon, we're talking Women's Health Month with Dr. Mitzie-Ann Davis, who is a board certified GYN oncologist, meaning that she treats gynecologic cancer. So anything that's woman related down below, she handles it. And there is some overlap. So let's talk a little bit about that specific overlap because like literally you just called me earlier today
Yeah.
about a mutual patient. So let's talk
Absolutely.
about like the reasons that we call upon each other and how one of the cancers that one of us deals with can impact, the other organ systems and how the symptoms can kind of overlap.
Absolutely. So I'm going to start with HPV cancers. So human papilloma virus. This is where Dr. King and I really work well together. And Dr. King actually started a clinic at Piedmont Fayette where anybody who's at high risk of HPV, and I screen them for cervical dysplasia, that's abnormal cells, I also send them to her. Or if they've had a diagnosis of cervical cancer. Okay, so HPV, human papillomavirus, is the virus that causes cervical cancer. Okay, other HPV-related cancers also include the vagina. So even though the cervix is the largest reservoir, the vagina can be affected. the vulva, which is outside, and right beside the vulva and the vagina is the anus. That's Dr. King-Mullins' area. So we have a vaginal or vulvar warts that's also involving the anus. We normally combine and have OR on the same day. I do the front part, she does the back part, okay? And then lastly, head and neck cancers. So these are all HPV related cancers. Now, there is a vaccine. This is the only cancer that has a vaccine to help to
Yes.
prevent these diseases, okay? So you see how many diseases I just listed? Cervical, vaginal, vulvar, anus, head and neck cancers. As a matter of fact, HPV surpassed smoking 2 years ago for the number one cause of head and neck cancers because
Yep.
of oral sex. Okay, so there's transmission between the cervix, the vagina, and the head and neck. So there's a vaccine to help to prevent this for women. There's a pap smear. There's a whole screening tool, the pap smear. And then for high-risk populations, with Dr. King-Mullins, they do anal paps. And you can talk about that, the high
Oh yeah.
resolution anoscopy, okay?
Yeah.
But this is where we share in this area because they're all close together. The rectum, so sometimes when I have vaginal cancers, they can be growing into the rectum, or cervical cancers that spread out to the sidewall, involving the bladder and the rectum. So our area, we work very closely together. Sometimes we have advanced endometrial or ovarian cancers that again spread locally in the pelvis, that can affect the colon, and sometimes we have to cut out a portion of the colon, a colectomy or a lower anterior resection. Sometimes those patients need a temporary colostomy. So that's where we work closely together. And I've called her in the middle of the night, and she's always there to, okay, I'll come help you. I appreciate it. So, but that's how closely we
Yeah.
work. Or if she has somebody who has had a rectal cancer, like a patient that we saw today, she has a primary rectal cancer, but it's growing into the vagina. At some point, once she has completed chemotherapy and radiation, if she's deemed a surgical candidate, then we will combine, and because I'm going to need to do a hysterectomy and a vaginectomy, and she can do the other part. So that's how
Yeah.
we work very closely with each other.
Yeah. So proximity is very important. And and I'm actually going to throw in a little tidbit because, you've been called me on a few even benign stuff too. So even diverticulitis from the colon
Oh,
side
yes.
can do all this crazy
No.
stuff and start causing fistulas into the vagina
Oh, yes.
and to all
Oh,
this
yes.
other stuff. But so a few stats, that we just need to make sure that we're aware of when we talk about the HPV virus. So like first and foremost, like the HPV virus is like everywhere. Okay,
Yeah.
everywhere. So the vaccine is recommended for men and women, okay? Because where's the women getting it from?
Thank you so much.
Men and women up to the age 45.
Okay.
45.
Between the
Um,
ages of 9 to 45, your
9 to
children. And
45.
I
Yes.
just want to interrupt you for 2 seconds. When this
Yeah, go ahead.
vaccine was rolled out, right, they made it seem as if it was a vaccine that was going to give you a free pass and you can do whatever. Here are the facts, people. HPV you can have it from either having sex half a time or 5,000 times. It makes no difference. But what you're
Exactly.
doing with this vaccine is helping to protect yourself. How
Yes.
God made us is that we're human beings, and procreating is a part of it. Having sex is a part of it. So you want to be able to protect these children, because eventually, when people get
Yep.
of age, they are going to have sex. It doesn't mean that you're giving them a free pass. It means that you're protecting them against the most common sexually transmitted infection, HPV. So it
Yep.
prevents cancers, these 5 cancers that I named. So
Yes.
please, I strongly encourage, if you haven't gotten it, men and women between the ages of 9 to 45 get the vaccine. Whether
Right.
or not you've been exposed or you had an abnormal pap, it doesn't matter. Okay?
Exactly, exactly. So by the time you reach the age of 40, over 90% of people have been exposed to the virus, right? It just lives everywhere.
It
And
lives
there's a
everywhere.
certain, and there's, so right now the vaccine targets 9 strains because there's so many strains of the virus. So the vaccine really targets the strains that have been documented to impact the formation of cancer, primarily HPV 16. That's the crazy strain, right? That's associated with the overwhelming majority. But the way I like to compare it to, because again, that's a good point that you made when we talk about like, hey, it doesn't give you a free pass to kind of like just go
Yeah.
buck wild. you know, we as physicians are recommended to get, like, for example, the flu vaccine, right? Because
Mhm.
once flu season comes around, we will come in contact with the flu.
Oh yeah.
And we don't want to get it and pass it to our
Yep.
families or to other patients. So
Mhm.
you are going to come in contact with the virus. How you train your body to fight the virus is what's important. And so
Yeah.
that's the best way to think about the HPV virus.
Well said.
Um, but then also when we talk about, the risks, because when I have these conversations with the women that you send to me, their first thing is like, oh my gosh, I've never, nothing's ever happened back there. They can't even bring themselves to say the word anus or rectum or anything like that. And so there's studies that actually document, the way we are trained in the US to, as we develop as women, that we are trained to wipe from front to back. We actually spread it to ourselves as women when we wipe. If you are having, active virus shedding in the cervical or vulvar area and you use the restroom and you're wiping from front to back, you're spreading that virus kind of towards the rear, and that's how it can get in the anal rectal area. Whereas in a lot of Central or Latin American countries, they're actually, as far as for what I'm told in some of the studies, they're trained to like more dab and blot
Mm.
as far as for after they urinate. And so they
Okay.
actually have less anal inoculation, or they have less spread of women spreading it to themselves from front to back just by nature of the physicality of it. So
Okay.
while the definition of, and this is for our listeners, and I'm going to actually, or viewers, and I think we got some questions that we'll break off to
Mhm.
in just a minute. But while we're told it's a sexually transmitted disease, yes, it is by definition because it impacts the sexual organs. But the true core definition of it is it's spread by contact. So
Mhm.
whether penetration happens or not, whether or not you have a condom on or not, if there's active virus in this area and active virus in this area, if they go like this, if you just lay it up, it can happen. Right. And so that is, again, the definition of how women can kind of spread it to themselves. You don't have to be like some crazy, promiscuous, like unscrupulous person at all by any means. And then also, we don't know when you present with some sort of HPV problem, we don't know if you acquired HPV on your very first sexual encounter in life or your most recent sexual encounter in life. And I find myself having to counsel couples quite a bit because it can cause quite a bit of
Oh yes.
contention
Oh
between couples. Like, you gave it to me, you gave it to me, this, and so it became, and so the key is that we're having these conversations about it that just no more, it's just everywhere. By the time you reach the age of 40, 90% of people have been exposed.
yes. Hmm.
Final stat before we go to some questions that are coming in the chat. So women are twice as likely to um, get anal cancer compared to their male counterparts, and 1.5 times as likely to die from anal cancer compared to their male counterparts, simply because we spread the HPV virus to ourselves from
Hmm.
front to back. Okay.
Hmm.
So Sonia's on the line. I'm going to let her chime in real quick and just let me know if we have any
Yay.
questions in the chat.
Yeah, we do actually. We have a specific one for Dr. Davis. Um, if you have had a CIN3 newly diagnosed and treated with WLE or partial vulvectomy for VIN3 just last month,
Okay.
what should be done to check, quote unquote, check the vagina for any dysplasia, etc.? She goes on to say, I had an HRA endoscopy by a GI doctor.
Okay. So the pap smear can be used to not only screen cervical dysplasia, but also the vaginal dysplasia. So if she is, so they can always, when they do a pap smear, it is looking at, honestly, if you don't have a cervix, they can scan the vagina. For the vulva, that's just only by inspection, by your eyes. Typically, vulvar cancers or vulvar dysplasia looks almost like a wart sometimes or a raised area, and we normally use vinegar, believe it or not. Regular table vinegar is 5% acetic acid. And what that does is the abnormal proteins absorb that vinegar and it turns white. So we can see whatever looks abnormal. All right. So that's how we screen. We screen for a patient that has had a history of vulvar cancer. It's by inspection and by using acetic acid on that area, and pap smears for the vagina.
Yeah. And
Wow.
And we do that very similarly, for the high resolution anoscopy, which it sounds like this patient got the HRA, the
Mhm.
acetic acid. We use that, the 5% vinegar in the area. We let it sit there for a little bit, and whatever kind of shines super bright white, we'll
Mhm.
biopsy that area, and that'll look under the
Yep.
microscope and let us know if there's any dysplasia. And for those who don't know, that's precancerous change. And that in the level of dysplasia and all of those things will dictate, like, how frequently we monitor you, whether or not you need a more advanced surgery just to kind of remove that whole area of abnormal tissue or not.
Yep. And I also want
Yep.
to, if you decided to get a hysterectomy, because as I said earlier, the cervix is the largest reservoir, that HPV, even though you get a hysterectomy, unfortunately, that is not the end of the story. That HPV can come back in the vagina and they still need to be
Mm,
screening. And you need to be screening for 25 years, okay? Yearly until you have 3 consecutive PAPs that are negative, then they can stretch it out to every 3 years.
yeah.
So super, super important. Also, patients in America, in the US that get cervical cancer are patients who are either under screened or not screened at all. So the patient that had their baby 10 years ago and haven't been back to the doctor, or the ones who have never been to the doctor. These are the people that get cervical cancer. If you are
Yep.
plugged in and getting frequent screening, you are not going to get cervical cancer because we're picking things up in their precancerous phases.
Yep. And to piggyback on that, that's why we're seeing the increase like year over year. If you go to the website for the American Cancer Society and all that stuff, that's why we're seeing the increase in risk in anal cancer in women because
Mm-hmm.
we're doing such a good job in screening for cervical cancer. And
Mm-hmm.
so if we rewind back to the conversation we just had about women kind of spreading it to themselves, it takes a while for the HPV virus to establish itself, set up shop, start causing these changes, and then over several years start causing cancer. So there's
Yes.
a lag time between being diagnosed on the kind of GYN side versus the posterior side. So we're
Mm-hmm.
doing a great job for identifying it in the cervical, vaginal, vulvar area and preventing cancer.
Mm-hmm.
But people are, by definition, living with HPV. So the women are, so it's eventually going towards the rear. And so while the average age of diagnosis of cervical cancer, what is it right now? Like mid 30s is what we
Yeah,
call it's like that
this is
median age.
unfortunately, yep, this
Yeah.
is unfortunately a
Yeah.
young woman's disease,
Exactly. But
and
for anal
women
cancer,
die
it's an
from this.
yes. And so for anal cancer, it's a more older woman's disease.
Mm,
So they're primarily being diagnosed between mid 50s to mid 60s
mm-hmm.
because someone's watching the front, monitoring it and keeping it in check. But people not minding the back. And so it's moved to the back and over
Yeah.
time. Now it's presenting as a problem in the back after all
Mm-hmm.
these years. And that's how women are developing, kind of the anal cancer. So we just have to make sure this word gets out now, mind you, if we monitor you and we do a few swabs, a few anal paps from the back, and the HPV never makes it back there, then fine, you're good.
Mm-hmm.
But we have to know if it's there or not, because
Yeah.
again, so we have the ability with the PAP to number one, determine whether or not there are abnormal cells, but
Mm-hmm.
also if the those high risk HPV strains are present, and that just lets us know, how frequently, we watch you for that.
Yeah, and that's the number one prognostic factor. The presence of HPV is what is causing this cancer. So we in GYN do co-testing, the abnormal cells and the HPV. But if the cells come back negative, but you're present, you have a high risk HPV, we're going with the high risk HPV. Okay,
Yep.
and those patients are going to need a colposcopy. And I mean, I've seen it all. I do a colposcopy. There's an invasive cancer there.
Yep.
Well, the pap smear missed it because the pap smear, honestly, is not
Just a
100%.
little
It's
sample.
about
Yep.
70%. Okay. So,
Yep.
super important that you're getting co tested. And quite frankly, eventually we're going to be dropping the pap smear. We're just going to be screening and testing according to the presence of HPV. If you have
Yep.
that, you get a colposcopy, biopsy, we'll go from there.
Yep. And again, to break it down a little bit for the viewers, when we talk about the pap smear, whether it's either in the cervix or the vagina or the rectum, and we're talking about, co-testing,
Yeah.
there's two aspects to it. So the pap smear, historically, before we really even knew what this whole HPV virus was, we were testing for abnormal cells.
Mm-hmm.
So that still right now is what happens. They do that
Yeah.
little swab, that scrape
Mm-hmm.
that's uncomfortable, but they're getting cells and looking under the microscope and like,
Yeah.
hey, are these cells abnormal? Are they starting to look
Yeah.
like precancer or cancer? And
Mm-hmm.
then the HPV is testing for the virus. So there's two strong components. And And again, like these are just samples. I mean, you're taking that brush and your spatula and you're just scraping. It's like taking a little mouth
Kind of
swab.
random.
We're just, it's random. It's picking up a few cells. And it's actually, pretty sensitive when we do both of them. That kind of
Yeah.
dictates how closely we need to watch you. But
Mm-hmm.
again, testing for that HPV, and especially those high risk strains that have been closely linked to cancer,
Mm-hmm.
that lets us know how frequently we need to watch you. Um, and even other factors besides the HPV virus being present, it's a virus. That means our immune system has to be functioning and working. So if you can please touch on a little bit about some of these risk factors for if the HPV virus is present, like why would one person potentially get monitored more frequently and more closely than another one, based upon their medical history and things like that.
Sure. I'm going to touch on a couple things. Number one, smoking and HPV. Hand in hand, they love each other. If you're a smoker, if you are a secondhand smoker, right, recipient of that, if you're chewing tobacco, all this stuff affects your immune system. These patients cannot clear this virus. Normally, HPV is cleared between 9 to 12 months, but the patients, or 10 to 15% of the population, cannot clear this virus. And these are the patients that are either immunocompromised, HIV, you had a kidney transplant, a lung transplant, you're immunosuppressed, or they are smokers. And sometimes you don't have any of these risk factors. But typically, this is where we're going to see this HPV population that they can't clear the virus and becomes incorporated. Also, you had mentioned earlier about, on average, HPV infection to cancer takes about 20 years, okay? This is a slow growing process. So that's why you have multiple opportunities to screen so that it doesn't get to a cancer. Okay, that's why it's important to get checkups. Very, very important. And then the other thing you spoke about was, what was the last thing you had mentioned? Sorry, what was the last thing you had
Uh,
mentioned about
so we just talked
so
about like
the risk
it being a
factors?
virus. So understand the risk factors for
Yes,
being like why
yes,
some people may get monitored more closely. Yeah.
yes. So HIV, patients who have HIV, super important. Once you have cervical dysplasia and you have cancer, we always have to scan. We really always have to be screening stringently because we know that you're increased risk of having a cervical cancer or anal cancer and or vaginal warts, vulvar warts. Okay, so we
Hmm.
see that all the time. As a matter of fact, I think when I see a really dense presentation of vulvar warts and anal warts, the next thing I do is check a HIV because typically patients sometimes don't know that's what they have. They're immunocompromised. That's why this HPV is just running rampant.
Yeah. And for me, so when we talk about immune compromise, we talked about the HIV, the smoking, poorly controlled diabetics,
Oh,
and specifically for me with the anal HPV, patients who have inflammatory bowel disease. So either
okay.
Crohn's disease or ulcerative colitis, and they're
Mm,
chronically on those biologic
yeah.
immunosuppressant medications,
Mm,
those have been documented risk factors as well.
yeah.
Um, and I see there's a message in the chat, even just HPV testing isn't catching it, the negative HPV tests, and still had the VIN3. So one of the things and that we don't know, and again, every physician's experience or what's kind of frequent in their area might be a little bit different. So some of their practices may be based upon what their geographic area location the hospital typically sees. But there's actually different types of HPV testing because, like I said, there's over 40, almost 50 strains of the HPV virus. And so, there's certain tests that only test for certain strains or not, but that's the importance of, like we talked about, the co-testing. You check for the abnormal cells, but you also check for the HPV virus. Now,
Mm-hmm.
there's a certain classification of women that don't have any of those risk factors. And they
Mm-hmm.
go on to develop cervical cancer, and we don't know why.
We don't
But
know why.
we don't know why. But we just know by definition of them in their bodies, for whatever reason it is, not being able to fully keep that virus in check, they're at high risk. And so we're going to watch them more closely for the development of cervical cancer, vulvar, vaginal, and colorectal cancer. And so that's why I say, like, even, when you send me those, and that's the importance of when I tell you to send me those patients who have been diagnosed with cervical cancer and they're
Yeah.
not HIV positive, they don't
Yeah.
have any of those things. I'm like, there's something in this person's body that has allowed this virus to advance to cancer. So that
Mm-hmm.
means if the virus has moved towards the back, we know that there's a good chance that their body won't be able to keep it in check. So we got to stay on top of it. And I'm going to jump forward just a little bit about treatment,
Yeah.
right? So the HPV related cancers are primarily treated first off by chemotherapy and radiation.
If it's advanced.
If
So
it's advanced.
cervical cancer, yes, a cervical
Yeah.
cancer, if it's early, like a
Hmm.
stage one, anything less than 2 centimeters, even less than 4 centimeters, we can
Hmm.
do surgery. But anything else above that, what we call locally advanced, if it's limited
Hmm.
to the pelvis, you'll get chemotherapy and radiation.
Yeah.
But there is a role for surgery, but it has to be very, very early.
Yeah.
Okay. And one, can I say one thing? I saw
Yeah. Yeah.
somebody
Yeah.
who said they were HPV negative and they still had VIN3. There is a subset of vulvar cancer that's HPV independent. These are patients that have lichen sclerosis, okay? That also increases your risk of having a vulvar cancer, but it's not related to HPV. So I just wanted to clear that up. Go ahead.
Yeah. And so, yeah, so that to your point, um, traditionally right now the standard of care for anal cancer, HPV related, is chemoradiation. And because most of it's caught late, and
Yeah.
so that's where the studies were directed. They're mostly most often caught stage 3 and above.
Yeah.
And
Mm-hmm.
so there's no real super accurate data on if someone's a stage 1, can we really just cure it by resection, or do they need more systemic therapy? And there's studies ongoing to kind of help us further delineate to make sure we're not over treating patients.
Sure.
But why this is key and very important that we have these conversations is, for example, if a woman has a stage 3 cervical cancer, gets chemoradiation therapy, and she's great, and then isn't screened and evaluated and checked for the potential of anal cancer and goes on to develop anal cancer, guess what? We can't radiate you anymore.
Oh,
So the primary therapy that's recommended is not even available because you've maxed
yeah.
out on your
Yeah.
chemo radiation for the safety of your body. And what do? We do what we call is an APR, an abdominal perineal resection, because the anus is right next to the sphincters. You need your sphincter muscles to be able to control your bowels. If we have to remove that, you can't control your bowels. So you get a permanent ostomy. You remove everything down there.
Mm-hmm.
So that's why this conversation specifically is so important, because without being screened, evaluated, tested, and prevention happening, you
Mm-hmm.
may literally be limiting, what's available for you
Your
for
option.
treatment, your options. So like, and even getting the APR, I mean, again, the gold standard of treatment is the chemo radiation. So
Mm-hmm.
you may not be fully affecting the different organs, because it very early will spread to the lymph nodes, especially in the groin and stuff like that. So surgery itself may not be able to fully cure the 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 precancerous or cancerous cells. It's able
Yeah.
to take care of the mass.
Yeah.
And so so there's just so many, it's Pandora's box. It
It is,
literally is
and
Pandora's
especially
box.
when you, and which is why we don't use, apart from if a tumor is greater than 2 centimeters,
Right.
we don't primarily use surgery for vaginal cancer, right? It has to be close to the cervix or small, because we can't, it is impossible to get clear margins. The
Yep.
space we're talking about potential spaces, just like a page in a book between the rectum, the vagina, and the bladder. It's all together. So
Yep.
it's very, these are radical surgeries. If we decide that this patient is a surgical candidate, they're going to end up losing their bladder or using their rectum and having a permanent colostomy. And a permanent colostomy is very impactful if you're 35, if you're
Yeah.
40, and you can live for another 30 years, changing a colostomy bag every day. So, these are the things, or when we offer a young woman a pelvic exenteration, which is the same thing. APR is just a posterior exenteration. Exenteration is a fancy word for saying that we're removing the pelvic organs because the tumor has recurred in a radiated field, Dr. King had discussed before, and that really is the only thing that we can do because we can't give any more radiation. So it really
Yep.
does limit your options, and these options are even more impactful the younger you are.
Yep. So I'm just gonna pause right now and just say, like, hey, like when we talk about, the vaccine, like this is why, right? This is to help because I mean, like, I don't know if you knew that you had a vaccine that could help prevent you from having a colostomy bag or just remove all your pelvic organs and all. I mean, like, sign me up.
Yeah,
Like,
if
sign
it
me up.
not yeah, all your pelvic organs. Trust me, guys. When you have a complete exenteration, where you have a urostomy, that's a bag for your urine, and a colostomy, a bag for your poop, it is not fun. These things get clogged. They get, the stents get broken. You have all sorts of, we call it stones. You have infections. It's these radical surgeries have a long sequelae. Okay, they have a
Yep,
long, long time of having a lot of problems that you're
yep,
in and out the hospital. You might be cancer free because that was the whole intention. But then you have a whole other issue with just dealing with the complications of that radical surgery.
yep,
That
yep,
oftentimes we can't go back in your belly because after we rearrange everything, it's just very challenging to go back in your belly to try and get a normal piece of intestines to put together to fix something. So these
yep,
patients chronically have wounds that we just literally put a drain in and just leave it because nobody wants to go back in your belly after doing all of this. And
yep,
again, there's a whole vaccine to help to prevent these diseases. So
yep.
we strongly encourage you to think about that. Even please, if somebody says to you, "Oh well, I was already exposed," please tell them, "Okay, you can still get it. You're still a candidate for it."
Yes.
9 to 45. So before
Yep.
it used to stop at 26. They have extended this over the last 7 years, and I am still surprised to see how many patients come to me and said that, "Oh, my doctor said I can't have it because I was already exposed." This is false information.
They tell you to get, like I said, they tell you to get the flu shot every year, right? You get
I
it, like it's this. It's designed to help train your body better fight the virus.
yes.
Um, Okay, so we got about 4 minutes left. So real quick, I'm going to ask Sonia, do we have any additional questions that we did not touch upon in the chat?
Yeah, there is one, and it taps into the mental health piece that you mentioned at the beginning of the conversation. Um, with serious diagnosis, this can take a toll mentally or emotionally on women, and we are the caregivers for our whole families usually, it says. So are there like specific resources or support systems that you all as physicians tap into that help lean women into, helping face these cancer diagnoses or these major surgeries, or just, even with the fear of not knowing what's wrong yet?
Yeah. So there's a lot of different organizations that are designed, number one, based upon the specific diagnosis. I know there's the Farrah Fawcett Foundation because little known facts, Farrah Fawcett, one of the what's it? Shoot. Now I have
Charlie's
to
Angel.
remember. Yeah, Charlie's Angels. So she died of anal cancer,
Yeah.
okay, HPV-related anal cancer. And then a few years back, Marsha Cross from
Yeah.
Desperate Housewives did release that she was battling with and got treated for anal cancer. So a lot of the different specific cancer diagnoses will have various foundations and organizations that are tied to having support groups and resources for that. Um, there are Facebook groups for everything. Now you got to be careful, right? Because some people are it's a
A lot of misinformation.
it's a lot of race to the bottom. Like they had they worse over worse over worse. But typically there's a lot of different like individual resources if you have some discernment on how to look through. But then also just kind of speaking with your doctors, especially if they're in a facility that has like major cancer services, with the different cancer specific navigation systems and social workers and case management teams, usually they can kind of help get you to a place where you can. 'Cause Dr. Davis and I can talk the medical jargon all day, but we're not living these truths. I don't have an
Mhm,
ostomy bag, and
mhm.
so I can tell you the basic day to day, but I mean, I can tell you the basic medical stuff, but the day to day life, I can't provide those resources and information. So we try to make sure we have that. Anything in particular you want to talk about,
Yeah,
Dr.
support
Davis?
groups really are the number one thing that you can do because it is, I think, more beneficial to talk to somebody who has started this journey, who has completed this journey, who is right in the middle of this journey to see exactly how am I going to feel. And I always counsel patients, not because I have listed all these different side effects means that you're going to experience it, but these are the most common ones. And then nationally, you have For each of these disease sites that I mentioned that I treat, there's an ovarian cancer society. On the south side in Atlanta, we have Hearts of Teal. I'm going to shout out Kim Earhart, who is a young woman with 5 children diagnosed with ovarian cancer and decided to use that energy, use her time and effort to providing a space for what they call their sisters. And it really has been so impactful on the south side. They have a run in the summertime. They have all sorts of other activities during the year. I just did a video for them, but they really have started with ovarian cancer, but they have really branched out to be a GYN oncology support group. There is ICON. I'm going to shout that out too. This is the Endometrial Cancer Network for African American women. Remember, I said that even though it's more common in white women, it's more deadly in African American women. And those patients they actually do a lot of research that they're published in the Society of German Oncologists. So it's not just about, support and so what we're going through. They're using their energy into making sure that they're recruiting more Black women in clinical trials, which is really what we need to make sure we know how to treat these patients properly.
Yeah. And on the colorectal side, there's the Colon Club that is focused a lot on colorectal cancers. Um, and for those who have to get an ostomy, the what's it called? Shoot. Um, Embracing Ostomy Life was founded by a former NFL player who actually had inflammatory bowel disease that had to get a permanent ostomy, but he created a nonprofit organization to kind of help link people who live with ostomies. So with various, because he actually went back to play in the NFL for like 7 years as a kicker with an ostomy bag. And so it's kind of that whole aspect of like how to live life and live life fully, despite some of these diagnoses. But I want everybody listening today, and I'm going to have Dr. Davis kind of give her parting words of kind of like the key takeaways that she wants women to know about their bodies and kind of maybe some of the hidden symptoms that we don't need to ignore. But the key is prevention. We're having these conversations because we don't want to have these long, morbid, freak you out kind of worst case scenario conversations where we have to direct you to these support groups because now you're living with like the unimaginable. Um, there are ways we can screen and prevent certain things. And I mean, we really did kind of go like, because there's so much conversation we can have about all of the different GYN cancers, right? We kind of really targeted a lot tonight on that specific overlap with HPV. So I'd love to invite you back for another day to talk a little bit more deeper into like the ovarian cancers, kind of like that specifically. But what are some key takeaways that you would have for our viewers tonight or anybody who may pull this up later, like just like if we had a super short snippet, like what would you say to those
Listen to your
folks?
body. Listen to your body. If something doesn't feel right, you're having this abnormal bleeding, go and get it checked out. This abnormal bloating, new onset constipation, go and get it checked out. If you don't like your doctor, get a second opinion. That's all I can do. Stress, stress, stress. Postmenopausal bleeding is completely abnormal. Get it checked out.
Yes, 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 yes. So, hey, listen, this has been like one of the most amazing Love Below series that we had. We just really want everybody to be in tune with their body, men, women, otherwise, like the below. We want you to fall in love with the below because once you
Mhm.
get in tune with what's going on down there, you can protect yourselves. And we didn't even get into the fact of like risk factors for other family members and all that stuff,
Oh
especially
yeah,
with
we even I
endometrial and
know.
GYN. So, loving yourself below loves we listen the below on down the
Hereditary
what
cancers.
the
I,
hereditary chain, the down the family tree.
yes.
But it's not just for yourselves, it's for those who are around you. If we want to empower our children to be able to speak up and take care of themselves and love their bodies and take care of their bodies. So a personal thanks to my work wife, Dr.
Thank you
Mitzie-Ann
so much,
Davis,
Dr.
board
King-Mullins. Thank you so much for
certified
having me.
GYN oncologist. Y'all tune in. We'll give you the shout out for our next Love Below.
Thank you, everyone. You have a good night.